permission of CMD sir and Director Finance sir, we are going to begin the health talk. So I invite Dr. Pal and Dr. Israel to kindly start the session, sir. Please.
Thank you, sir. Sir, am I audible?
Yes. Yes, sir, you are audible to us.
Yeah. So today my topic is, good morning everyone. I am Dr. Aruful Sheikh, consultant eye surgeon in Eye Care and Research Center, Biplabi Niketan, Park Circus, Kolkata. Today my topic is diabetic retinopathy. So let me start with that. So what is diabetic retinopathy? Diabetic retinopathy is an eye condition that can cause loss of vision and blindness in people who have diabetes. It affects the blood vessels of retina. Retina is the light sensitive layer inside the eye. If a person has diabetes, it's very important to get regular eye examination at least once a year so that we can detect the diabetic retinopathy in diabetic people as early as possible. In the early stages of diabetic retinopathy, there are no symptoms. But if we detect diabetic retinopathy in the early stage, then we can prevent the loss of vision and blindness. So let us now know what are the symptoms of diabetic retinopathy. Diabetic retinopathy often has no symptoms in the early stages, but as the diabetic retinopathy worsens or it goes bad, then the symptoms may appear. The symptoms may be as follows. Seeing an increased number of floaters, that is, floating black spots in front of your eyes, having blurring vision. The blur vision may suddenly get clear, then again your vision may get blurred. This is also one of the symptoms of diabetic retinopathy. Seeing blank areas or dark spots in your field of vision. This is also the symptom. Sorry. So I was towards the symptoms of diabetic retinopathy. So what are the symptoms? The earlier. So as I was saying, the early stages of the diabetic retinopathy has no symptoms. But as the diabetic retinopathy worsens, there may be symptoms like black spots floating in front of your eyes, which are called as floaters, having blurry vision. The blurry vision gets cleared, then again the clear vision becomes blurry. This is also one of the symptoms of diabetic retinopathy. Seeing blank or dark areas in front of your eyes in your field of vision, then loss of having poor night vision, noticing the colors may appear faded, and loss of vision. So these are the symptoms of diabetic retinopathy, which can happen in one eye or both eye, and usually it happens in both eyes to more or less the same degree. Diabetic retinopathy symptoms. Now, what are the risk factors of diabetic retinopathy? Anyone with any kind of diabetes can develop diabetic retinopathy, including type 1 diabetes, type 2 diabetes, and gestational diabetes. What is gestational diabetes? Diabetes during pregnancy is called as gestational diabetes. Also, women who are diabetic, when they get pregnant, they are at increased risk of getting diabetic retinopathy. The duration of diabetes is also directly proportional to the risk of getting diabetic retinopathy. Over the time, half of the people having diabetes, they will develop diabetic retinopathy. Having high blood pressure and high cholesterol along with diabetes also increases the risk of having diabetic retinopathy. So the risk factors are any kind of diabetes, pregnancy, gestational diabetes, high blood pressure and high cholesterol along with diabetes. These are the risk factors of developing diabetic retinopathy. Now we'll know how to diagnose, means how do we diagnose diabetic retinopathy. An eye doctor can diagnose diabetic retinopathy in their usual dilated eye exam checkup, which is very simple and painless. If the doctor feels that you have severe diabetic retinopathy or diabetic macular edema, that is swelling of your retina, he may order for a fluorescent angiography to look at the pictures of the blood vessels in the retina. Also, optical coherence tomography is one of the tools in which we can closely look at the retina and we can detect at what stage and whether the diabetic retinopathy is there or not. If a person has diabetes, it is very important to get regular eye exam from your eye doctor because detecting diabetic retinopathy early can prevent your vision loss by stopping the damage that is occurring in your retina. Now we'll come to the treatment of diabetic retinopathy. In early stages of diabetic retinopathy, your doctor will probably just keep track of how your eyes are doing. In later stages, it's important to start the treatment right away, especially if you have any changes in your vision. Starting the treatment at the right point is important to stop the damage in your retina. It's also important to take steps to control your diabetes, blood pressure levels, and cholesterol levels to help the medications treat your diabetic retinopathy. Now, what are the different kind of treatment available for diabetic retinopathy? So broadly, there are eye injections which are called as anti-VEGFs, that is anti-vascular endothelial growth factors that can slow down or even reverse the diabetic retinopathy. Other medicines that are sometimes used for eye injections are corticosteroids. So one is eye injection, the next is laser treatment. Laser treatment reduces the swelling in the retina, the macular edema that is swelling in the retina. With laser treatment, the swelling in the retina reduces. Eye doctors can also use a procedure called as lasers in the retina, which can shrink the blood vessels and reduce the leakage from the blood vessels of the retina. And ultimately, if the diabetic retinopathy is very severe and there is lots of bleeding or there is lots of scarring in the eye, then the eye doctor may recommend a type of surgery called as vitrectomy, in which we have to operate and remove the excess bleeding and the scarring from the retina so that vision can come back. The vision can come back, or it can help and it can prevent the diabetic retinopathy from getting worse. So these are the treatment. Now next, the important thing is how do we prevent diabetic retinopathy? Managing the blood sugar level in the normal range is the best way to prevent diabetic retinopathy from happening. You can do this by getting regular physical activity, eating healthy, and carefully following your doctor's instruction regarding your diabetes medicines and insulin if you are having insulin. Controlling your blood pressure and cholesterol can also help lower your risk for diabetic retinopathy. And the most important is having a regular eye exams for diabetic person, because if we detect diabetic retinopathy in early stages, we can start the treatment right away and we can prevent the vision loss and stop the damage, and hence we can also prevent your loss of vision or ultimately the patient from getting blind. So this was about diabetic retinopathy and the importance of early checkup, and in short, the risk factors, how to diagnose, how to do the treatment, and this thing, and the prevention of diabetic retinopathy. So if anyone has any questions, we can go with this regarding diabetic retinopathy.
If anybody has any questions, you may please ask Dr. Israel about eye related matters, whatever Dr. Sahab has said. Everybody is welcome to ask questions or doubts if they are having any.
Sir, how we can diagnose if a person maybe a person is not having suffering from diabetes, he doesn't know, but how we can diagnose what are the symptoms, early symptoms of being affected by diabetes?
Yeah, so that's the thing. If a person, as I've told, if a person has diabetic retinopathy in early symptoms, he may have absolutely zero symptoms,
Okay.
means no symptoms at all, because retina is a very broad area. So unless and until, and we see only from the center part of our eye or the center part macula. So if the diabetic retinopathy starts in the periphery of the retina, so the person will have absolutely no symptoms because the periphery of the retina is getting affected and he may not be conscious that okay, my periphery vision is gone. So what is recommended is that if a person has diabetes, he should get an eye checkup, especially a dilated eye checkup from an eye doctor as soon as possible. And if after that, if he has no diabetic retinopathy, then he has to get his eyes checkup at least once a year, the dilated eye exam, because in early stages of diabetic retinopathy, there is absolutely no symptoms because it starts in maybe it may start in the periphery, and the patients may not know that their visions are getting affected. So before you develop any symptoms, it's important that you have to go and get your eyes checked up. Usually, the patients who develop symptoms are usually the patients whose diabetic retinopathy has become severe. So in early stages, usually there are no symptoms. So that's the important thing, that before you develop symptoms, as soon as you know that you are diabetes, you have to go and get your eyes checked.
Sir, how will we understand that we are developing this diabetic retinopathy? Which you
Yeah,
said?
so actually, only the doctor can understand, and we have examination, that is dilated eye examination, in which we see the doctor sees the retina and he understands whether the retina is getting affected or not. And if he has some doubts or if he wants detailed examination, he can order for fluorescent angiography and OCT, which will absolutely make it clear whether the retina is getting affected or not. Now, the symptoms, as I said, the patient will not come to know, if the diabetic retinopathy is severe, he will have blurred vision, that is blurry vision. He will have floaters. Floaters means floating black spots in front of your eyes. Then he will have a blank spot in his field of vision. His color vision may get affected. So these are some of the signs in which, but usually these signs develop when the diabetic retinopathy has progressed a bit. So it is important that not to wait for the signs and symptoms for the patient. As soon as the patient comes to, as soon as the person comes to know that he has diabetes, he has to go for a diabetic eye checkup, that is dilated eye checkup. And it's a very simple, it's a 10 to 15 minutes procedure, and we'll come to know whether the retina is damaged or not. So so the point is that as soon as a person knows that he is diabetes, he has to go and get his eye checked up, because even if there is no symptoms, he may have diabetic retinopathy.
Otherwise, when it becomes critical, we'll get that blurry vision and all these things.
Yeah, so if there is critical, means the important part of the eye has been involved, that is the macula.
Yeah.
Usually, if the macula or a bit surrounding the macula is involved, then only the patient notices, because when the diabetes is in the periphery or something, then the field of vision the patient usually ignores, or it is not affected that much. So it is important that the patient comes to us as soon as he knows that he has diabetes. Because diabetic retinopathy is stage 1, stage 2, stage 3, or NPDR, mild, moderate, severe, and very severe, and then there is PDR. So these are the medical terms of staging of the diabetic retinopathy. So we would like to diagnose in mild NPDR, that is mild non-progressive diabetic retinopathy, non-proliferative diabetic retinopathy, and from there we will monitor, and if he goes from mild to moderate, then a doctor starts the treatment, that is maybe laser or this thing. So it is important that we come to know at least at the stage of mild NPDR.
Thank you.
Thank you.
Thank
sir.
you.
Sir, I would now request Dr. Pradeep Kumar Pal to say a few words on this topic, or else on any topic of eye care that is related.
Thank you, sir.
Thank you, sir.
Good morning to everybody.
Good morning,
Good
Are you
sir.
audible?
Yes, sir.
Yes, sir.
Yes, sir, you are audible, sir.
I'm Dr. Pradeep Pal from iCare. My
Welcome.
topic is common eye problem in children.
That's a very relevant topic, sir. Thank you.
Thank you.
So children are lovable by us, and sometimes their eye problem makes us anxious too much. Early detection and management of their eye problem is essential. Most commonly, eye problem in the childhood is first redness of the eye, which may be acute redness, which may be painful or painless, with or without discharge. Second thing is cloudiness of the cornea. Third is lid swelling and eye drooping. Fourth is the white reflex in the eye, that means we call it cat's eye reflex. And squinting of the eye, headache, and digital eye strain. These are more or less the common problem we get it. And regarding redness in the eyes, that is, first thing is redness of the eye is the conjunctivitis. Conjunctivitis, corneal ulcer in the subconjunctival hemorrhage, and ulcer with hypopyon, that means pus in the anterior chamber, or there may be blood in the anterior chamber. The first thing is conjunctivitis. Conjunctivitis may be of bacterial, viral, and allergic. In bacterial conjunctivitis, there are discharge in the both the eyes generally, and the discharge is pass like that, and eyelashes get matted, and discharge maybe it might be with fever or without fever. In viral conjunctivitis, there is no that much discharge. What is discharge is watery discharge, and that may be without any fever. Watery main thing is watery discharge, and allergic conjunctivitis, that is the redness, and discharge is less sticky, and there is itching of the eyes in the allergic conjunctivitis. In bacterial conjunctivitis, we just treat with antibiotic lotion, cleaning of the eyelids with boiled cotton, sterile cotton. That is thing. And viral conjunctivitis, we give some lubricant and antibiotic to save the secondary infection. And in allergic conjunctivitis, we do give some anti-allergic, but sometimes this anti-allergic drops does not respond, and in that cases we have to give low doses with steroids for 2 days. That is the regarding allergic conjunctivitis, and this is common. It is sometimes seasonal. In summer and winter climate, it comes generally in our countries. That is in the summer climate, in the allergic conjunctivitis, it happens. And second thing is that the redness with pain. That is redness with pain in the eyes. That is one thing. Is foreign body in the cornea. That is to be seen by slit lamp or any experienced teacher. They can see with the torchlight also. That the foreign body that is to be removed was the treatment and removal of the foreign body and antibiotic drop pad up for 24 hours. That is the treatment for foreign body in the cornea. Second thing is the corneal ulcer. Then you have to take any history of trauma or any fall, anything that is the history of trauma or fall in the on the eyes. The corneal ulcer, that may be a deep one, that may be a simple abrasion of the cornea. In those cases, we have to give the antibiotic drops, atropine drops, and antibiotic ointment at bedtime. And sometimes the chichiasis, that means lash having in the cornea, that sometimes gives the unilateral red eyes. Sometimes the bacteriocystitis, that also causes the red eyes. And second thing is that the ocular discharge. That is ocular discharge. It may be the since childhood, within 2 to 3 days, but those things are those are called the ophthalmia neonatal. But this types of patient is rare at present, and if it is possible, that is a passy discharge, swelling of the eyelids, and in those cases 2.5% forbidden iodine that helps a lot. Second thing is the congenital blockage of the nasolacrimal duct. There is a passage from eye to nose. The eye water goes to the nose in that through that passage. If it is blocked congenitally, then there is the watering since the childhood. And this in that cases, in those cases, the thing is that there is the nasolacrimal message and antibiotic drop. Those are the two things that is to be continued for 1 year. Generally, the obstructions goes up within 10 months to 1 year, and if it is not being relieved after 1 year, then that nasolacrimal dust is being tested with under GA by probing and syringing. We just do this nasolacrimal duct clear. And conjunctivitis, then the cloudy cornea. Cloudy cornea, the cornea is cloudy and sometimes the corneal size is increased and enlarged. In those cases, this is a common sign of the congenital glaucoma of ophthalmos. That is, the tension of the eye is more, which is an emergency condition. And in those cases, the examination under anesthesia, the tension to be taken, and if possible, the angle, because the cornea is hazy, so the inside angle is not visible most of the time. In those cases, the operation is only the treatment, and with the treatment, the haziness goes on, of course, the enlargement remains. Second thing is the lid swelling. Lid swelling, that is one thing is the sty, another thing is the callation. Sty is the pass point, and swelling in the lid margin, and which may precipitate with cellulitis also. So in that sty cases, that is the staphylococcus infection mainly, that is, and that cases the hot fomentations and antibiotic locally, and antibiotic if so it is more towards cellulitis than the antibiotic orally or IV antibiotic that is to be given. And in case of chalazion, it's the it is also swelling inside the at the lid margin. Here this hot fermentation and antibiotic drop that we will do. And that one thing, and that is the other thing is that white reflex in the eyes. White reflex in the eyes means which we call cat's eye reflex. That is in common in childhood, not common. That is present in some percent of the cases. That is the first thing is the congenital cataract. It may be unilateral or bilateral. And this second thing is the retinoblastoma. That is one type of cancer of the eyes. Third thing is that unilateral ROP or bilateral ROP retinopathy of prematurity, but it is less at present because it is a ROP program. And for that reason, every premature baby or your premature baby or on the Occident and those are giving, they are look for the retinopathy of prematurity and they are giving the laser treatment. So these types of retinopathy is not at present very much. But the retinoblastoma and congenital cataract, these are the two main things. But in congenital cataract, it might be unilateral, it might be bilateral. But congenital cataract, every congenital cataract is the treatment is operation, but every congenital cataract does not need to be operated. Any opacity within 3 mm of the visual axis, that is to be operated by surgery, that is to be operated, and that, but if beyond the 3 mm, if the vision is okay, then you can wait. If the congenital cataract is fully covered within 3 mm, then the unilateral cases we have to do it within 4 to 6 weeks of age under general anesthesia if it permits. In bilateral cases, this is that should be done with the 10 weeks of the age at 1 to 2 weeks interval of the between the two. And this congenital cataract is 1 to 15 cases in 10,000 cases. And that retinoblastoma, the thing is that it is to be screened by ophthalmologist, and it is to be dilated pupil, and in some laser treatment is given. Sometimes if it is more full eye, then exenteration is done in case of retinoblastoma. And sometimes ROP, that is also this red reflex, white reflex, that is to be measured by direct ophthalmoscopy from a distance of 1 meter if the two eye reflex is red, normal. But if one eye red reflex is thin, then we shall think of these things, the cataract, retinoblastoma, or retinopathy of prematurity. And one thing is also there, that is the persistent hyperplastic primary victors. These things are common in small eyes, microphthalmos. These things is persistent hyperplastic primary victors. And second thing, and another thing is squint. Squint may be that patient may represent with squint. Squint means eye turning to one side, either medially or laterally, or upwards, downwards. But this patient squints comes, generally it is, first thing is refractive error, second thing is the cataract patients may represent with the squint, and sometimes retinoblastoma patients also represent with squint. But first thing is refractive error, that is the refractive error if the muscle is the eyeball is medially, that is we converted squint. If the eyeball comes to the lateral side, that is called the divergent squint. That the refractive error in case of convergent squint is majority of the patient is hypermetropy. That means they need that the far side is okay, but near side is different. That is, we give the concave lens, that's the plus power. In divergent squint, they are short-sighted, they are distant vision, they can't see the far things clearly. So in those cases, we give them the minus power, and with the minus power, the squint sometimes get corrected. And if there is squint even after the correction, then the surgical maneuver is done. And that cataract, I have told you earlier, the cataract is there, that after cataract operation. And one thing, the refractive error, one thing with the squint, if the refractive error in the squint is much, then with the refractive error, vision can be cured, or vision can be normal with the glasses. In those cases, that we call it amblyopia, and amblyopia, that means that everything is normal, fundus inside is normal, externally is normal, but vision is best. In those cases, we do the refractive error first, correction the refraction. Second thing, we do the occlusion at different stages, 2 hourly, 6 hourly, that depends on the unilateral or bilateral case. And third thing is that headache. Headache is that it may be due to the refractive error or strabismus, or closer, then there might be accommodative spasm, convergence insufficiency. Then normally the patient convergence read point is convergence. It seems normally while reading, the two eyes converge nearly, but in this patient, the one eye is normal distance is for 8 centimeter in normal, but if the eyes turn to the one side, when the convergence, then the convergence is insufficient, and after reading, the patients will complain of eye strain or headache. In children, there may be a migraine also there. Children migraine is there. Children migraine in the childhood is also there. The symptom is the generally unilateral headache with nausea and vomiting, all this sort of thing. And the last one is the one thing is the droopy eye. Droopy eye, that is the ptosis we call one eye, or by the both sides, it may be from the congenital or acquired. That is, acquired is less in childhood, but mainly it is congenital. But acquired is in myasthenia. There might be the bilateral or unilateral also. But if the drooping of the eyelid, the ptosis that blocks the pupillary margin, then there may be no light passes to the eyelid to the eyeball. In those cases, there is the chances of amblyopia is more. So if the crosses the pupillary margin, then that is to be operated from the very beginning. It is to be operated if it is bilateral and neck tilting also is there to manage the vision. In those cases, it is to be done one after another. And last thing is the digital eye strain in childhood. It is the screen that is a discomfort in mobile or laptop or tab, blurring of vision, eye strain, headache, or watering. These are the mainly things of the digital eye strain in childhood. So in those cases, we have to do 1 20-20 regime. That is the after seeing the 20 minutes TV or laptop or tab or mobile, you have to give a gap of 20 seconds and look for the 20 feet distance. That is the 20-20 rule. And one thing is that the screen should be a bit below the visual axis. And neck posture should be normal and brightness and contrast may be adjusted according to the comfort of the child. These are the more or less the common eye problem in childhood.
Thank you, sir, for this
And
talk.
any questions from anyone?
Do anyone have any question? Can ask the doctor.
Yes, sir. I have one question. In nowadays, our children are working in online mode regularly, 8 to 10 hours, including their tuition. So, how to take care of their eyes in the present view regularly?
Present view, the two things that I have discussed, the 20-20 rule that is to be maintained. After 20 minutes, 20 seconds, and break and look at the 20 feet distance. That is the first thing. Second thing is the screen should be at the lower level from your vision line. Third thing is the contrast and brightness that is to be adjusted according to patient's use. And at present, some that is the anti-reflection coated lenses is there without any power. That anti-reflection coated lens is giving for the reflection protection. But computer, laptop, TV itself doesn't causes any harm to the eyes. These things are the computer, the digital eye strain from the children. They are using the mobile, laptop, all these sorts of things. At this during the Corona period, everyone is doing that work from home and classes from home, and they have to use the laptop, tab for 8 to 10 hours a day. And for those, these things to be taken.
Sir, can you tell something about dry eyes, sir?
Dry eyes in children, and yes, that is sometimes we see the dry eyes in those cases, those things. That is, if they look at the monitor for a long time, generally 10 times blinking is there. But if the blinking is less due to the state looking at the computer or PC screen, there may be the dryness of the eyes. In those cases, we have some the lubricant drop for that 3 to 4 times lubricating drops.
Thank you, sir.
Anybody has any other questions? Okay, then now I would request CMD sir to say a few words on this occasion.
I really thank Dr. Vishal and Dr. Paul for sparing their valuable time with us. We are really, their talk on diabetic problem and the problem in children are really helpful to everyone. And most of the people nowadays have a tendency of diabetes. So it is a very, very common problem nowadays. So I personally can say that every year I go for eye checkup due to diabetes, and all. My doctor has also recommended that. thank you very much again, Dr. Israel and Dr. Pal.
Thank you.
Thank you.
Session was very helpful to us. Thank you.
Thank you, sir. Now I would request Director Finance, sir, to say a few words on this occasion.
Sir, your sound is muted. Sir, your sound is muted. No. Go.
Sorry, sir.
Just a minute.
Just a moment, sir.
नहीं अनम्यूट হয়নি अनम्यूट হয়নি হ্যাঁ এতক্ষণে হয়েছে
Now I'm audible?
Yes, sir.
Yes, sir.
Good morning, everyone. I think today's session was very helpful for all of us. And I thank both Dr. Sheikh and Dr. Pal for sparing their valuable time and enlightening us on the today's very apt subject. Both the topics were actually very relevant to all of us. Where in line with our lifestyle, where there are increasing cases of diabetes. So Dr. Sheikh's talk on diabetic retinopathy must have enlightened us, and I think all of us will take cue from that and take proper care of our eyes, which are a very precious gift of God to us. And similarly, Dr. Paul's topic about the common eye care in children, and particularly I personally take a note of that 2020 rule that Dr. Saab has prescribed, and I think all of us will try to follow those guidelines for us and our children, so that their eyes are kept well. So, and again, I thank you very much, sir, for sparing your valuable time and guiding us on the topic. Thank you very much.
Thank you, sir. Now, on behalf of the BBJ Construction Company Limited, I thank Dr. Pradeep Kumar Pal and Dr. Sheikh Arnafil Israel, sir, for gracing this occasion and giving such a wonderfully informative talk on a very relevant subject of eye care. We are really indebted to both of you, sirs. Thanks a lot. So with due permission of CMD, sir, and Director Finance, sir, shall we conclude the program now?
Yes, please.
Thank you, sir. Thank you.